Take it away.
Right. Thanks, Jay. Hope everyone can hear me okay. So, as he already said, it is Antimicrobial Resistance Awareness Week. So, if any of you in the crowd are infectious diseases nerds like I am, and I'm going to lump Dr. Chawla in that category also, it's an exciting week, an important one. Any opportunity to raise awareness about AMR is a welcome opportunity for us. So, today we're going to talk about, or this afternoon, about pediatric respiratory tract infections. So this particular topic is one that is requested often by primary care providers to increase education, resources, support to help in assessment and management of pediatric RTIs. We know that kids are reservoirs and vectors for all kinds of infectious microbes. They often have viral infections, so it can be difficult to determine when antibiotics are indicated, and when they're indicated, which one do we use, what dose do we use, how long do we treat for. So Dr. Chawla and I teamed up in the last few months, created a resources bundle to do exactly this. And so I'm going to go through what those resources are, where you can find them. And I have a few other slides to go through. Then Dr. Chawla will give some high-level overview of some of these common RTIs. And then, like Jason said, we've left a lot of time for Q&A. So we hope that you guys in the audience have come armed with some questions for us. Okay, there we go. All right, so just to kind of set the stage as to why this matters. This particular graphic I have seen, I think hundreds of times at this point, but for me, it's always so motivating to see these numbers, and it reminds me every time I see it of why I do the work that I do. So it is projected that by the year 2050, we will see over 10 million deaths per year worldwide attributed to antimicrobial resistance. And to kind of further put that in context, at this point, we see about 1.3 million deaths worldwide attributed to AMR. So within the next 26 years ago, it is projected that that will exponentially increase. If we reach that number of 10 million, that will match the deaths that we currently see worldwide due to cancer. This will fundamentally change how we are able to provide healthcare services. So if we look at that in a Canadian context, there was a report published by the Council of Canadian Academies in 2019 looking at the societal impacts of AMR, so both the social and economic impacts. And this panel of experts estimated that by the year 2050, we will see resistance rates of 40% in Canada to first-line antimicrobials. And that's estimated to decrease Canada's GDP by $21 billion per year. So hopefully that's a number that gets the attention of politicians and policymakers in the country, and that we'll see approximately 14,000 deaths at that point in this country that we can attribute to AMR. So like I said before, this will fundamentally change how we can provide healthcare. So not only care to those patients who have infections, but prophylaxis for any surgical procedure or for chemotherapy. So when it comes to antimicrobial use in the community, we know that about 90% of antibiotics prescribed are prescribed in the community setting. There have been various studies that have tried to look at the appropriateness of antibiotic use in primary care. There was one published by a group of authors in Alberta within the last year or so, I think, doing just that. So looking at appropriateness of community-based antibiotics, and they found that about 40% of antibiotics prescribed were for indications that never require antibiotics. So things like asthma exacerbations or bronchitis, which is always viral. So 40%, it's a staggering number. And that's similar to other studies that have been done in Canada, and the CDC also reporting that about 30% of antibiotics used in the community are unnecessary. So this just goes to show that we have a bit of room for improvement. So RTIs are one of the top 3 indications that we prescribe antibiotics for. So important that we are using them as appropriately as possible. So like I said before, Dr. Chawla and I, with the help of some other stakeholders, created this bundle of resources. So I just want to highlight what some of those are. So we did a 3-part video series on common RTIs, pharyngitis, acute otitis media, sinusitis, and pneumonia. So short videos on assessment and management of these particular infections. So you can find those on our Antimicrobial Stewardship Program website. The QR code is there on the slide, and then the recording of today's presentation will also be included there. As well, we created an amoxicillin dosing handout. So when antibiotics are indicated for pediatric RTIs, amoxicillin is most often the drug of choice, but it can be a little bit tricky to figure out, do we give standard dose, high dose, twice a day, 3 times a day? So all of that is addressed in this dosing handout. So that can also be accessed on our website. As well, we know that family pressures, patient expectations are a big driver of unnecessary use of antibiotics. So any opportunity to increase awareness or provide education to patients, their families, the public in general is really crucial. So we created this poster. It's kind of a snappy poster. You can also find it on our website. It can be printed off, posted in clinics to kind of prime people to have that conversation about appropriate use of antibiotics. Another great tool, the viral prescription pad, also can be found on our website. It can be printed off, or our antimicrobial stewardship program is happy to send out pads of these. You just have to reach out to us. So another great tool to facilitate discussion with parents about the fact that their child likely has a viral infection, antibiotics are not indicated, how they can manage symptoms, and when they should seek follow-up if needed. Another critical resource for all things infectious disease is the First Line app. This is a free app. You can access it wherever you get your apps. And just make sure once you download it that you're choosing the right instance. So in Saskatchewan, you have 2 options. For anything related to pediatrics and infectious disease, you want the mom and kids instance. It's going to have guidelines for common infectious diseases, all the antibiogram information. And then for adult guidelines, you would choose the Sask Health Authority instance. So lots of resources out there to help with appropriate use of antibiotics. So that's it for me. I'm going to pass things over to Dr. Chawla.
Thanks so much, Kristin. I would start with thank you both actually for letting me become involved in this whole pathway of respiratory tract infections, because as Kristin has pointed out, certainly respiratory infections are by far the #1 overuse of antibiotics when they're not needed in the majority of cases. And hopefully these seminars will be helpful. As I said, I don't want to talk a lot. We really want to spend this time for you to ask your questions. I just feel very left out. I didn't get the blue background for the blue for AMR, so I feel like which one is not like the others. So anyways, so we're going to talk a little bit just in general. As I said, RTIs are definitely by majority viral. So if you look at the 4 that we went over through our presentations, pharyngitis, more than 70% of childhood cases and 80 to 90% of adult cases of pharyngitis are caused by viruses. And I said, major reason that we give antibiotics unnecessarily. Otitis media, so there's often an antecedent viral upper respiratory tract infection followed by secondary bacterial infection in greater than 90% of cases. Even though bacteria make up a large component, like 75 to 80% in sort of middle ear effusions, a lot of those bacteria actually self-resolve. And I can answer some of those questions in regards to this when we talk further. But again, 20 to 25% are culture negative, and those are mostly viruses. Next slide, sorry. Sinusitis. So again, sinuses are involved in sort of 90% of the cases of the common cold. And about 10% of colds, so it is a bit higher in kids. In children, do develop into acute bacterial sinusitis, but only 0.5 to 2.5% of colds in adults lead to sinusitis. And lastly, for pneumonia, the most common cause of pneumonia, especially in infants and preschool children, are definitely viral. As they get older, certainly bacteria become more involved, but viruses are a major cause of most pneumonia in younger children. Next slide. If you look at which antibiotics are used for these, I mean, we see a lot of antibiotics prescribed, but remember, first-line therapy for bacterial infections when you're dealing with respiratory tract infections really is amoxil, okay? Pharyngitis when they're adults is just with the Pen-V is probably the best, but knowing that we don't have liquid Pen-V is a big barrier in regards to kids getting Pen-V, but it's probably the most narrow spectrum for pharyngitis. But then again, amoxil can be used. Otitis and sinusitis and pneumonia, all are amoxil. Please use the dosing guides that we provided with some of the resources, but I'll talk a little bit on the next slide about high versus low dose. Next slide. Next slide. In regards to antibacterial, so when we use high dose, sorry, we have puppies running around here. In regards to antibacterial resistance, so when do we use high dose amoxicillin? So we use high dose amoxicillin purely for worry about resistance for the bacteria strep pneumonia, okay? So when we're targeting all these infections, we're really targeting the majority of the time strep pneumonia, and I said we can ask this more in terms of questions. In terms of risk factors that are most highly associated with antibacterial resistance is antibiotic use in the preceding 3 months and attendance in daycare. So if either of those are present, resistance is likely, and we would use more the high dose amoxicillin. Other factors to consider are definitely young age and recent hospitalization. If they have no risk factor, however, there's no reason to use high dose amoxicillin. High dose amoxicillin is not for more serious infection, it's for worry of resistance of strep pneumo. Next slide. So again, so this will be in your in the sort of the resources, but high dose, again, if resistance, you use the high dose, 80 to 90 milligrams, even up to 100 milligrams per kilogram per day. And you can use it BID when you use the high dose because it goes above the level of the MIC, just how, as we know, penicillins or the beta-lactams work. It will maintain that level at a higher level. But realistically, that's the only time you're using BID dosing for the amoxicillin. If there's no resistance, you're using the standard dose, like 40, 45 to 50 milligrams per kilogram per day divided TID. Next slide. Last thing I want to talk about is in regards to watchful waiting and delayed therapies. So there's two situations where we talk about this. One is in regards to pharyngitis. For me, some people suggest that if you are, if you have a McCusick or a McCenter score that is higher than 3, realistically give them a prescription, get them to start the antibiotics. My practice and what I would strongly recommend is you're still, even in the best case scenarios with center scores of over 3, and 4 or 5, you're getting rates like about 50% are still viral, okay? So realistically, you're starting antibiotics on a large percentage of the population that do not have strep. So remember why we're using the antibiotics. It's really to sort of prevent complications more than what the patient wants, which is improved symptoms, which the antibiotics don't do all that well, basically a day at maximum. So what I do is I give them a therapy, but to only fill it when the throat swab or culture or the rapid antigen detection test is positive. If it's not positive, do not start. There's no point of giving the antibiotics till then. The other situation, which will, next slide, is an otitis. So if you look at otitis, in regards to if you're over 6 months of age, if you're mildly ill, meaning that the patient is alert, responsive, has no rigors, is responding to antipyretics, has mild ear pain, is able to sleep, temps less than 39 in the absence of antipyretics, and less than 48 hours of illness, you can get them to observe for 24 to 48 hours and ensure follow-up in medical care and recommend analgesics. Again, a lot of family physicians and people are very busy. It's important to sometimes recognize that realistically, what I sometimes do there again is, inform the parents, watch for those 2 days, give me a call, here's a prescription if they get worse. A lot of the big thing is a lot of these people are busy. They don't want to come back. They just want to start the antibiotics. This way they have the antibiotic prescription and then you can delay that prescription, delay that time. Often the biggest, rate limiting step is getting into the family doctor to see them twice before in a short period of time, as we know that that can be quite a struggle. Next and last slide. So lastly, just as Kristin had mentioned, we really do recommend everyone please have the First Line app. Again, this is across the country. There's different sites that it's important to know where your site is, and it has more local information for us in Saskatchewan, specifically for the Jim Pattisons in Saskatoon. The Mom and Kids site for the pediatric information gives more information for pediatric samples. This is available both on the Apple Play as well as the Apple Store as well as the Google Play Store for free to download. And I will stop talking and we will take your questions. Thank you.
Thank you both very much. I guess I'll just put it out there. Is there anyone who has questions? Either raise your hand or unmute yourself. and let us know. Maybe I'll start off while people think. So I guess one of my things, and you mentioned the delayed prescription, which is, I think, a great tool for especially primary care providers to be able to use to help if people have trouble getting back to, for a second appointment or something like that. Another one that we often promote with the antimicrobial stewardship program is the viral prescription pad. And so there's a pediatric version as well. And actually I put a link into the chat. So I don't know, do you have any experience using that, or is that something you would recommend for folks, or you want to chat about that at all?
I love it. I think Do Bugs Need Drugs has provided that, has sort of created that. I've often written it down. I think people really respond well to the fact that I've always written on a prescription pad, these are the things to watch for. Even things that are non-prescription based. I think a lot of people respond to the fact that they know what to do, when to come back, and it looks official. It's on your prescription pad. So it's the thought process of they're still being provided something. It's not that we're ignoring them. And more the importance is in regards to instructions of when to come back, what to look for. So that's where the prescription pad. I haven't actually used the viral pads, so I'd love to see them. But I said I've often just almost created my own and written them down for people because they feel like it's like I'm writing a prescription for them.
I think it's important for people to feel that you have assessed them, you've come up with a plan for them. They want to feel, that you're caring for them that way. I'm curious, Dr. Chawla, because often parents come in with the expectation of antibiotics. They're tired, they have a sick kid, they just want to do something to help their kids feel better. Do you have any tips on having these conversations with parents, ways to phrase things that have worked well for you in the past?
I think the big thing that we probably ignore more than anything else is analgesia, and using analgesia properly, the dosing, how frequently to use it. I think simple symptomatic things are really important. Rest, time, those are how I sort of start. And I said really expectations in terms of what antibiotics are going to do, and especially for viral, and stating that viral illnesses are not benign. People get very sick with viral illnesses, and that things can get worse and get secondary infections as well, with secondary back. So again, the two big things that I push is one, that viral illnesses are not benign, and actually in some ways they're worse because we really can't make you feel better faster with using antibiotics, but also what to look for with getting a secondary bacterial infection. And I said often that time in the situations where I can give that delayed prescription that feel okay, if things are worse, this is what we would do. I think that helps people feel, okay, I've got the comfort that I don't need to worry that I have to come back. And, I think the biggest thing is people's time is very important to them. And they feel like, okay, if I don't have to make another trip, it's often a big thing for people to get childcare, to get their one sick, get into hospital, and sort of respecting their time is an important thing.
Great, thanks. I see, Mel, you've got your hand up.
Yeah, thanks, Jason. And thank you very much, Dr. Chawla and Kristin, for your presentation. I'm curious, Dr. Chawla, as you pointed out, amoxicillin is a drug of choice for a lot of these respiratory tract infections. What is your approach in a patient who is reporting an allergy to penicillin?
So it really depends. I think that's a really good question. I think we do have a resource in regards to antibiotic allergy. I'll let Kristin talk specifically about that, but I think over-reporting of allergies is probably one of the biggest things we deal with in pediatrics. People are labeled as having penicillin allergy when it's not true. So really getting a clear aspect of what the reaction is with the penicillin antibiotic is really important. A big part of this is a lot of viruses rash when you're younger. And if you give antibiotics, they develop this allergic type, not allergic, more a rash. And this is often an idiopathic rash that you develop with antibiotics that aren't truly allergic in nature. So I'll let Kristin talk specifically about the sort of the resource that's on the site. But often I find, even with going through the history of what sort of reaction they've actually had, you can find that it's probably not a true allergy that these patients have had. And you can go ahead and feel comfortable using the penicillin. But again, if there's a clear history of an anaphylactic type reaction, then, you know, I think it's a very different situation where one, if they haven't been labeled like properly tested, I would get them tested for, you know, with allergy testing by an allergist, as well as then using a different class of antibiotics if there's a true anaphylaxis type 1 allergy. Kristin, did you want to talk more about the resource that we have?
Yeah, such an important point, especially in pediatrics. So we know that about 10% of the population reports an allergy to penicillin, but less than 1% are truly allergic. And often, like you said, what gets reported in kids is kind of this delayed benign rash that happens many days after starting an antibiotic. Maybe it's from the virus, maybe it's this idiopathic reaction you said, or it's just a delayed reaction to the antibiotic, which is not a contraindication to continuing to receive penicillins or to receive them in the future. So also on First Line, there's a penicillin allergy delabeling tool, which walks you through this assessment and very easily can flag those people who are really low risk of having a true allergy, who it's safe to give penicillins or beta-lactams in. It also has guidelines or guidance on cross-reactivity between beta-lactams. So if they do have a true allergy to one beta-lactam, could a different one be used, say a cephalosporin? So there's guidance on cross-reactivity also. Mel, I don't know if you have anything else you want to add when it comes to pen allergies.
No, I think you guys have highlighted and covered everything that I would have wanted to discuss. The main point being a lot of patients report allergies. The majority of patients can safely take penicillins. And there's tools out there to guide clinicians on how to make that assessment and promote the use of penicillins for these for some of these bacterial infections, which is the drug of choice. Because then when we're not doing those assessments, where it's resulting in more broad spectrum antimicrobial use, which increases risk of side effects and further drives antimicrobial resistance. So there are great tools out there, and thank you for highlighting that.
Yeah, most often then we're using macrolides as second line, right? Which resistance rates to strep pneumo are not great. So ideally, we're not using them. Any other questions from anyone?
I just want to highlight one thing. So Amanda had put in the chat here, as a parent, she appreciates the delayed prescription. It cut down majorly on the antibiotics that her child has had. So I just want to highlight too, because I think something that I know Kristin has started including in some of our presentations is talking about the microbiome and the effect that antibiotics have on the microbiome. And we are still learning more and more how important the microbiome is and a healthy microbiome is in development. And so treating children with antibiotics earlier on in life can have a lot of effects on their development as they grow. So I don't know if that's something, Dr. Chawla or Kristin, that you guys want to chat about too, as another reason why we would want to be careful with prescriptions for our kids.
I think that's always a consideration. Fortunately, kids do not get as much C. diff as adults do, but when they get C. diff, sometimes they can be notoriously difficult to treat. We don't know the full effects of the microbiome. I think there's a lot of new information that's coming out how important that is, not just for gut health, but other parts of their health. So if we don't need antibiotics, again, part of it is, again, why are we making these bugs resistant? But what are we doing to our own bodies by affecting normal flora that's in there, especially when we're talking about broader spectrum antibiotics. And even we have to realize, even though Moxil is considered very narrow, it has some broad spectrum activity against bacteria that we're not necessarily even wanting to cover. So we are affecting the microbiome in a significant way. And the problem is there's not a lot of data in regards to how well other things are to protect us with the microbiome, like probiotics and things like that. It's very unclear. There's a lot of people who sell probiotics, but the data on probiotics is fairly sparse in terms of true randomized control studies that protect yourself in terms of with use of antibiotics. So I think the less that you are using it for indications that are not required, the less we're going to have problems with affecting your microbiome. That would be my comment.
Yeah, I really don't have much more to add. I think both of you have highlighted the main really important points. And I guess I'll just reiterate that we are just beginning to understand the effects that taking antibiotics have on the microbiome, but then how that affects our overall health. And I think there was a study even done in BC that now shows an association between increased use of antibiotics in childhood and incidence of things like asthma. Again, just an association, that's not a causation, but I think we're going to be finding a lot more in the coming years as this is studied more.
Scared to even mention it, but one of my preceptors in Calgary, who's one of the world experts on C. diff, actually did stool transplant there for kids with autism. So we don't know if there's a clear indication, and everyone sort of sneers and snickers behind his back. But we don't know. We don't know what sort of things are out there, and you know, it's definitely that is not just gut health that the microbiome affects.
All right, thanks. I've got a couple more questions rolled in here. So Andrea says, thanks for the presentation. Can you speak to the situations where amoxiclav may be more appropriate than plain amoxicillin?
I think that's a big point. I think amoxiclav is pretty rare in terms of being needed for the majority of these respiratory tract infections. The majority that when we're doing this and why we're using amoxil is that we're really considering that strep pneumo is the #1 agent, #2 agent, and #3 agent for all these infections. A lot of other bacteria that are involved here are ones that either self-resolve, especially when you consider things like otitis media. Strep pneumo is the one that tends to persist and give you ongoing symptoms and cause the complications, versus H. flu and Moraxella are ones that sort of self-resolve. In terms of pneumonia, it's really not a very common cause of pneumonia. And of course, pharyngitis is, we're talking about group A strep, not strep pneumonia. And that's where we're, you know, really the only choice is Pen-G or amoxil. And sinusitis, similarly, again, that's probably the one that I tend to, if I have resistance, then I don't improvement, then I do go to clavulin a bit faster than the amoxicillin because other bacteria can be involved. But realistically, clavulin is really not ever should be considered a first-line therapy. It should be second, third-line therapy in these situations. I don't know if anybody else has anything to add.
And just to add on to that, and you already talked about this, Dr. Chawla, but the resistance of strep pneumo to amoxicillin is due to changes in the penicillin binding proteins, right? It's not a beta-lactamase, so there's no need to add on the amoxiclav. That's why we give higher doses of amoxicillin when there's risk factors for resistance, so no need for that clavulanate.
Exactly. The answer is more, not a different antibiotic.
All right. Amanda has another question here. So is the Healthline equipped with information on watch and wait, or when antibiotics are helpful or not helpful, that they can share with parents calling in regarding their children?
Don't know the answer to that. Does anybody know?
I don't either. Yeah. If anyone from or associated with Healthline is on the call, let us know.
Yeah, I have no idea, and I would be curious to know who we would even contact to suggest that, if anyone knows.
Yeah, that might be a great initiative for our antimicrobial stewardship program. We can reach out and see what kind of information they have or don't. So yeah, thanks, Amanda. Okay, I want to ask a question too. So kind of on this other avenues line. So Kristin, I'll maybe put you on the spot because I know you work in community pharmacy as well. And we've got a few pharmacists on the call that I recognize some names. So from I guess, what would you perceive are the barriers for community pharmacists trying to help ensure that kids are getting the most appropriate prescriptions and things like that when you see mom come in or whatever picking up a prescription for their child? Is there anything from your perspective what could help community pharmacists ensure that we're providing the most appropriate prescriptions?
I think there's probably quite a few barriers. One being that, they're not privy to the whole assessment that happened of the patient. And often when you ask parents those questions, they don't necessarily have detailed answers that they can give you. Did the doctor look in the ear and, what did they see? Parents don't really know the answer to those. So it's difficult to really make a clear, or to know what that assessment was, to know whether antibiotics are really indicated or not. And of course, time is another barrier, actually having these conversations with parents. And but it's so important. So whenever I work in community pharmacy, even if I'm dispensing an antibiotic because it might be indicated, I always try to take the time to educate parents on, the possible consequences of using antibiotics so that they know for the future, and telling them resources that they can look into, and to ask their doctor, are antibiotics really indicated? And to have those discussions and be an advocate for themselves and their children. So, I mean, it's kind of a start of an answer to your question, I suppose, but many possible barriers.
Yeah, I think that is just very much the case, right? There's a lot of things to consider. So yeah. What else do we have here? Melanie McKenzie has said she worked for MedSask for many years, and many calls regarding antibiotics for children were transferred from Healthline to the MedSask pharmacists, who would then recommend watch and wait, explain why antibiotics are appropriate. So that's good that they do have a connection there then too. All right. Other questions, comments, experiences from the group?
We don't bite, we promise. You can ask.
Rupesh, how much RSV are you seeing in kids already? High rates of RSV? I haven't looked. I know our rates of influenza are high, but
our rates of influenza are through the roof. When I was just on service last week, I was just reading that RSV has markedly increased in the elderly lately. I'm waiting. I don't know if it's gone across to the pediatrics, but we had just a smattering of RSV, but that was a couple weeks ago now already. So as you know, that can change within days. So influenza was our major hospital filler a couple weeks ago, but that may have changed. We're really hoping for a milder RSV year. Oh my gosh.
I have microbiologists on the call, so maybe they can chime in also. I don't remember, I know in adults, rates of secondary bacterial pneumonia in people who have influenza is, fairly high, up to 30%. What is the prevalence in children? I don't know that.
I couldn't quote I mean, that seems pretty correct. I mean, our hospital is filled with secondary bacterial pneumonias, severe, often group A strep pneumo. I haven't seen any bad Staph aureus yet, surprisingly, but I'm sure it's to come. But we've had a lot of group A strep pneumo, empyemas, and we were dealing with a lot of secondary bacterial pneumonias on the ward. So that percentage seems very appropriate. Yeah, Amanda, I can see there, it just said that the rates of flu are very high overall. Thanks, Amanda.
Do you, I know when at the height of COVID in the hospitals, we were looking at the treatment of COVID patients in hospital with antibiotics for people, worried about secondary infections and stuff like that. And we were treating 70-80% across the province of hospitalized adults with antibiotics. And that went, right through wave 1, 2, 3, whatever, 4. Do you know, and yet we knew that, all of the evidence that was continually coming out was this is 5, 10, maybe 15% at the most of people who would actually have a secondary bacterial infection. Do you know if that's similar amongst children? That was literature that I did not actually look into.
Realistically, most of our pediatric COVID cases were in the younger age group, more bronchiolitic type patients that got admitted during Omicron. Otherwise, they were very much adult-like patients when they were adolescents and had the risk factors like adolescents. And then I would agree. I think it's not like influenza where we're seeing a lot of secondary bacterial infection, but I think almost all of them got antibiotics if they got admitted.
All right. So yeah, thanks Amanda for chiming in there. I see, and I see Dr. Shahab has also shared a site there. Okay, so I guess, speaking of websites too, so that one that I put in the chat at the beginning, the Choosing Wisely Canada Primary Care Antibiotics, that I think for anyone who is interested, is a great site. So if you haven't heard of Choosing Wisely, they are it's really an international organization. We've got a Choosing Wisely Canada. And they have some really great information for primary care, particularly, but as well long-term care, acute care, and any specialty really in medicine. They've got all kinds of information, not just around antimicrobial use, but all kinds of use of healthcare resources, and ensuring that the right testing and treatment is going towards patients, and we're doing all that appropriately. So their primary care website actually has links to the Using Antibiotics Wisely toolkit, which I think is in its 4th iteration. They've just recently released a new toolkit around bronchiolitis, I believe. So yeah, there's some really great resources there, including those like the delayed prescriptions, like Dr. Chawla was talking about. They've got viral prescription pads on there for pediatrics as well as adults, and lots of great posters, pamphlets, just information that you could have in family clinics or in pharmacies for that matter. Community pharmacies, or even just around the hospital in pediatric wards or at JCPH perhaps too. So lots of great tools and resources there for people to check out if you're interested. Okay, I don't see any more questions. So maybe what I'll do, I'll just give each of you, Kristin and Dr. Chawla, an opportunity to just provide any last thoughts, and we'll close out from there.
Go ahead, Kristin. You can start.
Yeah, I think we've covered a lot of good content today. So just encourage everyone to check out the resources that are available. Lots of organizations doing some great work. So if you have any questions, please feel free to reach out. And thank you all so much for your engagement with this topic and for, just antimicrobial resistance and stewardship in general.
And again, remember that respiratory infections are a major cause of overuse of antibiotics. So please think about when you're going to prescribe an antibiotic. Is it truly going to make a difference? Make sure you talk to parents, give them good follow-up, use the antibiotic, delayed prescriptions, watchful waiting techniques, and please have first line. If you deal with kids, I think, or adults, in my mind, if you're taking care of patients, I would hope that you all have the free first line app on your phones. Thank you guys so much.
All right, perfect. Well, thank you both very much for your presentations today, and for engaging and opening up to an Ask Us Anything session. So I hope everyone has an enjoyable rest of the week. Please take part in any World Antimicrobial Resistance Awareness Week activities that you can. And remember, Friday is the Go Blue for AMR. So wear a blue shirt, turn the blue lights on, and do what you can to raise awareness about this important issue. Thank you everyone for joining us today.
Thanks everyone.